Thank you for the opportunity to present today. Mainly, I'm going to focus today on a broad array of research that we're doing in clinical research in Chiari and Syringomyelia. Much of it is focused on work that we've done through the Park-Reeves Syringomyelia Research Consortium, and out of that emerged a clinical trial, the posterior fossa decompression with or without duroplasty trial, PFD trial, and one or two studies that have emerged yet again from Park-Reeves and some of the other work that we've been doing. So this is just a really broad overview of the work we've been doing. And the PFD trial, the posterior fossa decompression trial, is supported through the PCORI, which is the Patient-Centered Outcomes Research Institute. And as part of the funding for that trial, I try to come and present and give an overview of the progress that we've been making over the last 6 months, or as often as Dorothy will let me come and present. So with that, and many of you are familiar with some of this work done through Park-Reeves. So Park-Reeves is a multi-institutional North American research effort that's aimed at improving the medical and surgical care of patients with syringomyelia associated with Chiari malformation. And it really was formed to be a multidisciplinary, multi-institutional collaborative. So there are neurosurgeons, orthopedic spine surgeons, and family representatives. And we'll talk about this a little bit later when we get to the PFD trial, but we also have patient partners, patient advocates like the Chiari and Syringomyelia Foundation and so forth that really play a vital role in that study and in helping us to make sure we're answering and asking the right questions. So, you know, when we initially started Park-Reeves, which was just becoming up and running around 2011, our goal was to accrue data, clinical radiological data, and outcomes data on 1,000 subjects with Chiari and Syringomyelia. And we started out just with 12 sites, and then that became 16 sites and 25 sites, and now we're at 42 sites. And you'll recognize many of the sites here, and the investigators are here in the room. Now, again, when we think about the first phase of this, which was Park-Reeves, we began by having two arms, which are over on the left side of this image here, where we had inclusion criteria, which were quite broad actually, and we were focusing mainly on surgical outcomes. So you can see that we had a retrospective arm, and this is a group of patients who had surgery sometime in the past, and we focused on those who had at least a year, hopefully 5 years of follow-up. And then prospective patients, so after the consortium was in place, if they had surgery, we would collect their data prospectively. It wasn't long afterwards, with the input of Cormac and Jerry Tuitt and a number of others, that we decided that we would actually have a conservative management arm. So we do have natural history data on a cohort of patients who met the criteria for surgery, but for one reason or another, they just never had surgery. Sometimes that was the patient or the family choice, and sometimes it was the practitioner's preference or recommended plans. We do have some conservative management patients as well. And what we saw over the first several years is, even though our goal was to get to 1,000 patients, we rapidly reached that goal, actually. So we have a complete clinical, radiological, and outcomes data on 1,000 patients, and we hit that milestone in 2015. And you can see that the angle of the curve dampens there, and the reason is we got rid of at that stage, since we'd accrued the data that we were hoping to from the retrospective patient group, we just continued to accrue prospective-only patients after that. And you can see that as of a few months ago, we were somewhere up to 1,100 patients. The actual number of patients that we've accrued is closer to 1,400, but the images aren't yet uploaded for some of those, so that's the reason for the discrepancy there. And as we sort of undertook this effort to learn as much as we could about clinical outcome, clinical presentation, and so forth, what we noticed, and this has been greatly improved over the last several years, but what we noticed at the time was that most of the reports that were coming out were using just a gestalt impression of a clinician if patients were doing better or not. So rather than having a general quality of life instrument or outcome scale, or hopefully even a disease-specific, like a Chiari or Syringomyelia specific scale, very few had those. Almost everyone was reporting just Gestalt outcomes, which were almost always categorized by the treating physician. So within Park-Reeves, we began to use the CHIP, which is the Chiari Health Index for Pediatrics outcome instrument. This is a health-related quality of life instrument developed by our collaborators at Vanderbilt, Chevis Shannon and Jay Wellens and others. And this looks at pain, it looks at quality of life function, whether people are able to meet those sorts of goals within their life that they would like to in terms of academic achievement and things. So we began to implement the CHIP in Park-Reeves a few years ago, so we have this quality of life information. And of course, we collect a broad array of craniovertebral junction parameters. Now, not anywhere near what we have seen in some of the reports earlier. And the reason for this is that when we had 1,400 patients, and if you think about it, we have pre-op and post-op imaging on all of them. Oftentimes, if they got scanned every 3 months, every 6 months, every 12 months, and so forth, we had all those images. And our central radiologist was about to kill me, actually. So what we decided to do was limit the number of parameters that we would collect data on, and we actually focus on the 1-year MRI scan as well. But we do have all those other scans, and there's one investigator from University of Wisconsin who is drilling down on some of the more detailed measurements that many of which you heard earlier in the reports today. But we collect tonsillar position, syrinx diameter and length, the PBC2, which you can see in the middle panel there is depicted there, the Grab-Oaks line also, the clivus canal angle, which again you can see is demonstrated there on the right side. And we do collect information on CSF flow and true FISP, which is a dynamic image. And I came in towards the end of Dr. Loth's presentation, and I missed Bryn's presentation. I know that our methodologies are similar, although the analysis is not as advanced as what was presented earlier. But we do use true FISP, which again is a dynamic image. And then, of course, when available, we collect information on the ventricular size, which is more often volumes now, but at the time was FOR, or the frontal occipital ratio. And we've gone over time to sort of validate some of these metrics. This is a recent paper by Todd Hankinson, Jerry Tewitt, Rich Anderson, Jim Torner, and others through Park-Reeves, who went on to investigate the reproducibility of PBC2, just as one example. And they found that any reviewer within reason would be able to assign this value with some reproducibility and validity. And this is, again, looking at true FISP, so this would be a dynamic radiological marker. And I do have a video here. I'd say it plays about half the time, so forgive me if it doesn't play. Before I do play it, and again, we saw some of this earlier today, so the technique will not be novel, but I think just you'll be able to appreciate from this view the amount of tonsillar pulsatility here that you're going to see after I play it. And then what I think is interesting is you'll see in sequence, if you look at this, that the tonsil has that sort of so-called pistoning motion downward, and then secondarily you'll see the syrinx compress. So I'll go ahead and play it now. And we did publish this a couple years ago, where we looked and we found a measurable displacement, which was worse in symptomatic Chiaris and worse in Chiari rather than control. And on the right side, you can see after surgery that the syrinx is greatly reduced in size, and again, the pulsatility is essentially eliminated. So I know that some of this was touched on earlier, and our analytic methods are sort of Cro-Magnon compared to what was presented earlier, but nonetheless, we've been investigating this over time as well. And again, what we've tried to do is to look not just at Gestalt kind of impressions, whether somebody might get better from surgery or how they got better after surgery, we've been working to sort of nail this down a little bit, so we created this Chiari Severity Index. The lead author here was this resident here, Jacob Greenberg, who's done a fantastic job. You'll see him threaded throughout this presentation, actually. And what he did, as we heard earlier in a couple of the presentations, is he was able to use clinical parameters and radiological parameters to be able to anticipate who might do well from surgery and what kinds of clinical problems might be most inclined to improve following surgery. So he used these advanced statistical methodologies, including sequential sequestration and conjunctive consolidation, in order to compile this data and create this Chiari Severity Index. And again, the utility is not just to be able to better inform your patients of what parts of the symptomatology might respond best to surgery, but it also is useful for stratifying patients for clinical trials. And again, we'll see that in just a bit. So within Park-Reeves, we've identified different working groups. And just to give you one example, this is my partner in St. Louis, Dr. Jen Straley, who trained with Cormac, who knows Jen very, very well. And she has been studying the interrelationship between Chiari Syringomyelia and spinal deformity. And this is a study out of Park-Reeves that's been presented and is just ready to be submitted she showed that older age and syrinx length were associated with larger curves in terms of curve severity. And she did not identify a number of other parameters as being significant predictors of curve severity, and you can see what those are: syrinx width, cervical syrinx position, and so forth. And then she looked at if you do surgery early on in a child who has spinal deformity, what's the likelihood that that spinal deformity will respond to surgery? And what she did is she found that younger age at the time of diagnosis and younger age at the time of decompression were associated with a greater chance of improvement in curve associated with Chiari and Syringomyelia. And then Cormac and I have been investigating the role of upfront fusion and upfront ventral decompression in the setting of Chiari and Syringomyelia. As all of you know, this is a controversial issue. When are these more advanced and more involved techniques used? And what we did is we went back and looked at the Park-Reeves data, 640 patients, and you can see whether they had PFD, posterior fossa decompression, with or without duroplasty. And what we found was it was actually quite rare to have an OC or occipital cervical fusion. In fact, it was only performed in 2% of patients who went on to actually have at least a year of follow-up. So it's relatively infrequent. And if you talk about ventral decompression, it's even less common. Ventral decompression is performed in less than 1%. So what we can sort of really think is that these techniques, while we think about them and read about them quite a bit, fortunately, they're actually quite infrequent. What we then did is we sort of said, well, is there anything we can do to predict who might need one of these? And we looked at the various parameters: tonsillar position, syrinx size, PBC2, and the one predictor that seemed to be strongest in terms of being able to predict OC fusion, whether that's delayed or upfront fusion, or delayed or upfront ventral decompression, was the clival canal angle. And I was just having lunch and we were talking about the relevance of this metric just a few moments ago. So here's just one example of this. So here's a patient who had 19 millimeters of tonsillar ectopia. Syrinx diameter was actually rather modest at 3 millimeters. The PBC2 was 11 millimeters, and the CXA, or clival axial angle, was 122 degrees. And this patient, in the clinician's view, was taken for upfront OC fusion with a posterior fossa decompression and duroplasty. And why don't you just for a second look at this image here. Hopefully it projects well, and compare it with the left image here. So this is a patient who had 14 millimeters of tonsillar ectopia, a larger syrinx at 8 millimeters. The PBC2 was 7, and the CXA was 124 degrees. So they had posterior fossa decompression with duroplasty only. And then they went on to develop, a year and a half, 2 years later, choking and balance difficulties and gait ataxia. And a repeat MRI demonstrated that the syrinx diameter was actually more attenuated. And the PBC2 was similar, but the CXA, the clivo-axial angle, was significantly reduced. So this person went on to go and have a delayed OC fusion. So what did Cormac and I take from this? We again felt like the vast majority of patients don't need these advanced and somewhat more involved techniques. And it seemed to be that clinical factors, brainstem symptoms for example, and the clivo-axial angle or CXA seemed to be what was driving the clinician decision in these cases. The one thing that became clear to us, is that we need to have improved phenotyping of what parameters exactly are relevant for directing patient treatment, especially for these more advanced treatments. And what is it about this complex Chiari that helps us or what can we take from it that helps us to understand who might need these treatments? Now, I don't need to tell anybody here in the room that in general, pediatric neurosurgeons and to some extent adult neurosurgeons as well sort of wrestle with this question about what operation to do among these two very broad categories, posterior fossa decompression without duroplasty or with duroplasty. And this question has been very well studied in small series, and I think that most would agree that PFDD, this is the duroplasty, is associated with higher rates of neurological complications, CSF leak, pseudomeningocele, aseptic meningitis, and longer OR times, maybe longer admission times. But it may be associated with a higher rate of clinical improvement, maybe even radiological improvement in terms of syrinx size, and we just don't have an answer to this. It's been studied through a number of different reports, including from our own center. And this, when we talked to Park-Reeves investigators, was the primary question that we felt like we could contribute with high-quality data. So we applied for, and fortunately were successful in obtaining funding to answer this question. The study that we proposed was endorsed by the AANS, the CNS, and the Joint Section for Pediatrics. It was funded through PCORI, as I mentioned earlier. And it functions as a cluster RCT, or a cluster randomized controlled trial, where we are comparing by site PFD and PFDD. And of course the objective or the impact of the study would be to identify the surgical approach that, number one, minimizes surgical complications and harm to patients, and two, maximizes symptomatic relief and syrinx resolution, and three, produces the highest quality of life. And it's that last bit that is the most important, I think most would agree. And again, the intention of this study is to create a paradigm shift away from our reliance on individual surgeons' preference or experience or small individual case series, and provide high-quality data on which to make clinical decisions. So this is a small print slide, and the details are not important. This is just to show the workflow of the study, which really follows ordinary clinical workflow. We do follow up at 1 month, 3 to 6 months, and 12 months as well. And again, the primary outcome is harm to patients, surgical complications, or reoperation for complications. And then the secondary outcomes, we're focusing more on efficacy. And this is looking at clinical symptoms, neurological deficits, syrinx size, spinal alignment, and importantly, the need for revision surgery, and then quality of life with the chip, and then a standard index of quality of life called the HUE-3. Now, with any RCT, getting the regulatory documents through individual IRBs at 47 sites takes some time, as you might imagine. So our trial started last summer, and you can see that St. Louis, our hospital, was a little bit ahead of the curve as the primary site. So we enrolled a number of patients, but it wasn't until everybody's regulatory documents were approved that we were really able to increase our enrollment. And as I was putting these slides together earlier this week, our enrollment was 60, and it's actually 61. Somebody was enrolled yesterday. So we really have sort of taken that exponential curve and are really having great success with enrollment at this stage. Now, the last thing that I really wanted to talk about here is sort of that emerging project, and this is one that we've been working on for a couple of years now. We were fortunate to be awarded a spinal cord injury research program grant in order to do gene discovery in Chiari Syringomyelia. And based on that, we collected the first 400 DNA samples, and we collect DNA from patients, but also we do a pedigree analysis and collect it from any willing and able family members as well. And we have the first 400 have undergone whole exome sequencing, and those data are going to be available within a week or two, actually. It just so happens they're coming online right now. Our goal is to collect on an additional 600, and we've formed a group of committed Park-Reeves sites in order to do that, led by the Washington University site and Chris Gurnett, who is a neurogeneticist at WashU, and then also by Doug Brockmeyer at the University of Utah, who's very interested in this topic as well. And then, again, several of you in the room from Stanford, from Duke, Vanderbilt, Ohio State, and the University of Alabama, Birmingham as well. And again, what we're really focusing on is getting high-quality sequencing data, so not just looking at specific genes, but looking at the whole exome. And in fact, for the next 600, we're going to be doing whole genome sequencing, not just whole exome sequencing, and that's a subtle difference, which I'm happy to go into if you'd like. And we're focusing on copy number variants, new mutations, and joint hypermobility at the moment. These are some of the promising genes that we've found, and I think that probably will make sense to everyone in the room. And this particular project, I think, is really of utmost importance and relevance, especially at this point. So, how do we put it all together? Of course, Park-Reeves really focuses on the 3 phases of patient treatment, evaluation, treatment, and most importantly, outcome. So just sort of putting it all together, we have been focusing on craniovertebral junction parameters from a radiological perspective. We've been using advanced MRI techniques like TrueFISP, for example. We've been able to have develop a Chiari severity index to help inform patients, but also to help us to stratify clinical trials such as the PFD trial. For treatment, we're looking not just at treatment broadly across Park-Reeves, but we have this randomized controlled trial at this stage. And in terms of outcome, we are using Chiari-specific outcome metrics, the CHIP, radiological outcomes, whether somebody goes on to require revision surgery, and also short and long-term outcomes. And of course, most importantly, the front end, which is the genetic propensity towards Chiari Syringomyelia and perhaps hypermobility and other conditions that are related. So that's how we're going about it at the moment. Obviously, we're really excited about all of these things, and especially the genetic project at the moment. And I just want to take a second to say thank you to all the Chiari and Syringomyelia patients and their families. I do know they watch these videos. Thank you. And also the Reeves family, who helped us to create the Park-Reeves Consortium. And CSF, of course, has been instrumental in helping us to form our local St. Louis CSF chapter, which I feel has taken off very, very well. And also supporting the trial, not just from advocating for it, but also on social media and so forth. So thank you guys. And then, of course, our funding organizations and the various individuals who've been involved. So thank you.
Thank you, David. That was an excellent presentation. Questions from the audience? While others are thinking what to ask you, I have a question. The prognostication index for either occipital cervical fusion or anterior decompression, did that study include contribution of hypermobility, hereditary connective tissue disorders?
So that study is actually very much still in process. I presented the early results, which you see here at a meeting previously, but we have not from a genetic standpoint, but it has from a clinical standpoint, right?
Hey, thanks so much.
Yeah, thank you.
Beautiful, comprehensive approach. One thing about the posterior fossa decompression study was the randomization as I think you call it the cluster RTC, which seemed from kind of the lay statistical mind, we always used to try and get an even number of the randomized into each group or institute. What was the advantage of that? I heard that there could be some feelings of the researchers if the whole institution is randomized into a certain group that it might not satisfy all of them and so forth. What are the advantages of using the cluster approach? I'm sure there are some.
Yeah, there are a number of advantages, and I think that so when you look at the other randomized controlled trials that have been done in surgical disciplines, including neurosurgery, is that for any given patient, once they're randomized, the crossover rate is extremely high. So crossovers are one of the major issues, and then oftentimes the surgeon or investigator will not always stick with the allocation that is given in real time. So our approach for this, based on our investigator meetings and so forth, was that we felt like since the cluster is 6 patients, that's what the cluster is, so it's a group of 6 patients, and all the different sites agreed that for a group of patients, and if we all have equipoise, and if they meet certain criteria, and I'll remind me to circle back on that in just a minute, that it made actually the investigators feel much more comfortable, because they knew for people meeting these criteria that there was equipoise for this group of patients. And in many ways, I think it made the patients feel more comfortable as well, that they knew that they were part of a group that was going to be treated based on their own specific disease in a similar way to other people in the institution. And then one side benefit that our clinical trialist who informed the development said is that oftentimes people have biases, and this includes surgeons, clinicians, and of course patients who are very well informed. And we were trying to avoid this practice of people sort of wandering to different institutions and so forth. So that's how we came to the cluster design. So what it is, a cluster is a group of 6 different patients who are treated in a very similar way. And each institution is charged with doing 6 patients. Now, how we came to equipoise is a kind of a different question, and what we did is we sent a series of images and questions and a red cap kind of questionnaire to our investigators, and what we did is everybody answered the question in the way that they felt which treatment would be best, and if there was a common kind of picture in terms of patients that could be equally treated with either. And so what we did is a simple vote, and it came down, the margin was very crisp, which was it was in the high 90s, were for this group of patients which have tonsillar position 5 or more millimeters below, and a syrinx diameter between 3 and 10, so 3 to 9.9 millimeters. We were afraid that if you started including syrinx size out to 14, 15 millimeters, that there wouldn't be equipoise, and that's how we came to that. Thanks.